All right, let's talk about a bug that's often called the Great Mimicker. It's a true master of disguise in tropical medicine, and if you work in the north of Australia, you've got to know it inside and out. We're talking about melioidosis.
So picture this. It's the classic exam question, right? But it's also a very real scenario walking into your ED. You're in Darwin, it's pouring rain outside, and this patient comes in. Now, just from that sentence alone, a whole bunch of alarm bells should be going off. The question is, what are the clues here that should make melioidosis shoot right to the top of your differential?
To answer that, we've got to build that differential diagnosis. And it all starts with the basic epidemiology, the classic questions. Who gets this? Where do they get it? And when are they most at risk?
Okay, so first up, where and when. This is not a subtle disease. It has very clear hotspots. Our patient in Darwin, he's in the absolute global epicenter for this thing. And he's presenting smack bang in the middle of the wet season. And that's key, because all that rain brings the bacteria Burkholderia pseudomale right up out of the soil and into the environment.
Now, for the who. When it comes to risk factors, there's a big three you need to have burned into your brain. And number one, by a country mile, is diabetes. Honestly, if you only remember one single predisposing condition for severe melioidosis, this is the one.
Number 2 on that high-risk list is hazardous alcohol use. And we're not talking about a minor link here. This significantly weakens a person's defenses against this bacteria.
And rounding out our big three is chronic kidney disease. So let's put it all together. You've got a patient in the wet season, in the right location, with a septic picture, and they have diabetes, a history of heavy alcohol use, or CKD. Boom. Melioidosis has to be on your list, no question.
Of course, it doesn't stop with just those three. You also need to be thinking about patients with chronic lung disease, and certain occupations, like our construction worker, put people at higher risk. It's also incredibly important to know that Indigenous Australians are disproportionately affected, often getting sicker younger.
So we know who to be suspicious of. Now let's talk about what to be suspicious of. And look, there's a reason we call it the Great Mimicker. Once someone's infected, this thing can look like almost anything, from a simple skin infection all the way to catastrophic multi-organ failure.
Now, pneumonia is the most common way it shows up. That's about 60% of cases. But you absolutely cannot get tunnel vision. This bug can present as overwhelming sepsis, it can cause deep abscesses in the liver or the prostate, and it can even cause these rare but truly devastating neurological syndromes. Your index of suspicion has to stay incredibly high no matter what the presenting complaint is.
Okay, so you're suspicious, the patient fits the profile, the clinical picture has you worried. What do you actually need to do? What are the immediate life-saving steps you take right now in the ED?
Right? This is your game plan. Don't overthink it, just do it. You're going to treat this like any other potential sepsis case. That means multiple sets of blood cultures, a full septic workup, sputum, urine, any wound swabs you can get, your standard bloods, and of course, a chest x-ray. The key is to get this rolling fast.
Your clinical suspicion is what gets the ball rolling. But the definitive diagnosis, the gold standard, is growing this thing in the lab. That is non-negotiable. And you need to cast a wide net. Blood, sputum, wounds, but also add throat and rectal swabs to really maximize your chances. And here's a massive clinical pearl. Pick up the phone. Call the lab. Tell them you suspect melioidosis. They need to know so they can use the special selective media to find it.
All right, let's talk treatment. Getting the antibiotics right and right away is what saves lives. And you need to think of this as a marathon, not a sprint. The management is broken down into two very different phases, a really aggressive IV phase up front and then a long oral eradication phase.
And this table lays it out perfectly. Phase 1, the intensive phase, is at least 2 weeks of heavy-hitting IV antibiotics, like meropenem or ceftazidime. Then, once they're stable and through that, they switch to Phase 2, the eradication phase. And this is a long haul, a minimum of 3 months of oral antibiotics, usually trimethoprim sulfamethoxazole. If you cut this phase short, the risk of relapse is huge.
I just want you to pause and look at this number for a second. The mortality rate in Australia now is down around 10 to 20%. But historically, it was closer to 90%. That unbelievable improvement isn't because the bug got weaker. It's because we got better. It's because of early recognition, better diagnostics, and amazing critical care. What you do in those first few hours is a direct part of that success story. Okay, let's boil all of this down. What are the absolute high-yield, must-know facts that you need locked away? The stuff you need whether you're about to walk into a Russ's Bay or sit your fellowship exams.
Here it is, your cheat sheet. 1. Recognize the pattern. Wet season, the classic risk factors, and a patient who looks septic or has pneumonia. 2. Diagnose. Think cultures, cultures, cultures. 3. Treat. Start with the big guns IV, meropenem. 4. Treat again. Follow up with that long oral eradication phase. And 5. Notify. Don't forget this is a notifiable disease in Queensland.
And I'll leave you with this final thought to chew on. We think of this as a top-end disease defined by its geography, but that geography is changing. With shifting climate patterns, are we going to start seeing this pop up further and further south? It's a question every single clinician in Australia should probably be thinking about.
And that's our look at melioidosis. If you found this helpful, do us a favor and hit that like and subscribe button for more practical, high-yield emergency medicine content. And hey, we want to know what you're struggling with, what you want to see next. So drop a topic in the comments below, and we might just tackle it in our next one. See you then.